Today's workshop is, the beginning of the upcoming series of workshops to ignite the scientific activities for the upcoming national conference. And this workshop, wherein we are going to discuss some basic to advanced situations, we are going to have number of cases to start with the cochlear implantation first case, with many other rhinology and head and neck procedures. Hopefully, till 5 or 6 o'clock this evening. Then, as our Dr. Tarun Reza boss has announced, we'll be having series of hands-on workshops also before the AOICon 23 to make it memorable for the junior colleagues to give them hands-on experience in Jaipur. So thank you, boss, for all the efforts. And for this case today, there's a young child having bilateral profound sensorineural hearing loss and has been chosen as a candidate for cochlear implantation today. Though, of course, we are doing unilateral implantation, we all know bilateral implantation is the state of the art now in the present scenario. So as far as the cochlear implant is concerned, we all know ever since it started, it has gone, tremendous development, not only in the development in the surgical technology, but in the development of instrumentation, better understanding of the anatomy of the cochlea and further higher auditory pathways, better development of the technology in terms of various, innovative electrodes and implants, more and more options for the different category of patients who are candidates for the implantation. So this science is developing like anything. One of the fastest developing field in the medical science, I would say, in the past couple of decades. You can imagine when this cochlear implantation started few decades back, the indications were very limited for selected children, prelingual deaf children with certain degree of hearing loss above 85 degree or so, with certain criteria for to be candidate for cochlear implant. But with now, with the advancement in the technology, advancement in the development of this science, the indications have been expanded, and now by and large, any candidate, irrespective of the age, irrespective of prelingual, postlingual, whatever scenario, any candidate which is not benefited by hearing aid for the sensory neural hearing loss is by and large a candidate for cochlear implantation, provided the basic functioning unit is intact. This is very important for everybody to understand the indication, the basic functioning unit for the cochlear implantation. And for cochlear implantation, this basic functioning unit is what we are implanting. We are implanting the electrode to stimulate the nerve endings in the cochlea, wherein the cochlea has become non-functional. So in order to for the implant to be successful, what all we need is a intact fluid-filled cochlea and an intact eighth or the cochlear branch of the eighth cranial nerve. That is very, very essential for an implant to be successful. And a fluid-filled cochlea and the intact cochlear nerve. These are the two important prerequisites for a cochlear implant to be successful, functional, and effective. So this is very important. So for choosing the candidates for implantation, as I said, the indications have been expanded. Not only for the prelingual deaf children, adults, even the elderly patient. Age is no bar in the present scenario. Even the 80-plus-year-old people have been implanted who want hearing. Provided the basic functioning unit is intact, they are fit for the medical side and all that. So anybody can be implanted where the hearing aid is not working, provided the basic functioning unit is intact. For this, a lot of other workup is required for this implant to be, optimally effective. For children, we have more, selection criteria as compared to adults. For prelingual children, where the speech is the main, factor, the development of the speech is the most important factor. In the parents' involvement, their medical workup, their audiological workup, their radiological workup, there's so many, immunization workup, and all these things are important for carrying out a successful cochlear implantation. So, as far as the workup is concerned, As I discussed, you can see the CT scan on the screen. The radiological workup is very important. Similarly, audiological workup is very important in order to choose a good candidate for the successful cochlear implant. Then, as I said, immunization workup is important, particularly for children, to prevent post-cochlear implant infection, particularly pneumococcal infections, which are dreaded infection, can lead to meningitis and even life-threatening. So everything is important, and particularly for the children, the parents must be committed for the overall better outcome for the implant as far as the speech development is concerned. So a lot of sessions are spent with the children, their parents, in order to prepare them for the surgery and the post-operative rehabilitation and the overall outcome. So it's a overall a teamwork wherein audiologist is a prime member or the most important member, I would say, beside the surgeon for this overall successful program, cochlear implant program. So before I go to the radiological part, anybody, Sunil Sandani sir, if you want to say anything or any questions or anything before we proceed to the important radiological part.
Yeah, Satish, I just wanted to add, when you say that all the candidates who are not benefiting out of the hearing aid are the candidates irrespective of the prelim or
By
the
and large, yes.
so I would just like to add that the hearing aid quality should be a top quality hearing aid, which has a proper gain for the severely or profoundly deaf children or moderately severe. Because appropriate fitting of the hearing aid and the trial of the speech therapy perioperatively is important to eliminate unnecessary cochlear implantation in some cases. So it should not be a just routine hearing aid and speech therapy. It should be a properly fitted, appropriate hearing aid.
Yes, that's a very important message from sir. See, cochlear implant cannot be a replacement to the hearing aid. It cannot be anywhere close to the quality of hearing what we get from a good hearing aid. See, cochlear implant, whatever hearing it provides, has a narrow spectrum. The dynamic range of hearing what we get from the cochlear implant is very narrow as compared to the acoustic hearing we get to the hearing aid. So hearing aid cannot be replaced by cochlear implant. So as long as the hearing aid work means the best available hearing aid, if the patient is happy with the hearing aid, with the quality of hearing, cochlear implant is nowhere indicated. So that has to be very, very clear. Now coming to the radiological part, why it is important for the surgeons? The radiology is important for the radiologists. Why we surgeons are so concerned about the radiology? Because we want to extract the maximum anatomical details, which is useful in carrying out a successful and a safe surgical, operation for this particular patient. So from radiology, if we take the kind of radiology required, what all we need is both a CT scan and MRI for the different indications. CT scan is important to give you anatomical details of the temporal bone, particularly bony details, which are important to know in carrying out surgical operation in that area. You need to know the three-dimensional anatomy of that area, particularly the anatomy of the cochlea and the surrounding structures, facial nerve, facial recess, so many things, vascular anatomy around. All those things are important in carrying out a proper operation. Similarly, MRI is important. As I said earlier, we need to know the basic functioning unit intact for a candidate to pass, eligibility for a cochlear implantation. That is the cochlea, which should be fluid filled, and the intact eighth cranial nerve or the cochlear nerve for the cochlear implant to be effective. And that is best seen by the MRI. MRI is known to give the best soft tissue details, and CT scan is known to give best, bony details. And both have investigations complement each other to get the maximum information before surgical planning. This is very important because many of these patients, particularly children, have malformations, congenital malformation leading to profound sensory hearing loss. Though many of the patients' malformations are not visible even on the radiology, because what we see on radiology are bony malformation. The malformation at the membranous level cannot be picked up by radiology, and still many patients looking like normal on radiology, we may face complications, what we face in malformation. So we have to be in any situation prepared for all those complications, but still a good radiology can give you a proper pathway for a good surgery. So CT scan is important, MRI is important, and we need to know how to read and how to get the maximum information out of which. Otherwise, radiologists are, either you have to make a team with the radiologist to know what all information you know from cochlear implant perspective. If I send a CT scan to a radiologist to report, they will report in single line the normal anatomy of the temporal bone. That is of no use to us when we are planning a cochlear implant surgery. What all is important to us when we are planning a cochlear implant surgery? To know the anatomical details in relation to the surgical procedure of the cochlear implantation, in in order to know the anatomical abnormality which can pose difficulty during surgery. All those things which can pose difficulty during surgical procedure, we must know beforehand to plan our surgical technique accordingly. We may have to change our surgical technology according to the the radiological information. We'll discuss during this details of the CT scan. So
Satish boss, good morning. Kapil Sikka here.
hi, good
I'm sorry
morning.
I joined late. Yes.
We are waiting for you, man.
I'm sorry, sir. Sorry for delay.
So for the everybody, the Kapil Sikka has come in, the most dynamic, who has been committed otologist and one of the pillars in extending, taking this cochlear implant program ahead in the All India Institute of Medical Sciences, the
Thank you, sir.
prestigious
Thanks
institute
for
of our
good.
country. And Kapil has been always been academically oriented and committed to teach each and everybody. So Kapil, we would like to have your comments,
I
your
have been listening to
observation,
you, sir.
the
I think
benefit of everybody.
I have been listening to you, sir. Listening to you and Samdani, sir, for some time now. I
We
just
need,
wanted to ask you and
yes,
engage in discussion. Many patients, they come to you with a CT scan that is 1 year old or 1.5 year old, and they come to you for implant now. Do you repeat it or do you take it at value, the old CT scans?
yes. See, I have already mentioned the CT scans are, ordered to get the anatomical details, 3D anatomical details. So if somebody is holding a CT scan in hand, what all I will request him to have a digital information. I want the CT scan in digital data to extract 3D information, because in digital data, I can convert to 3D and get three-dimensional anatomy. But sometimes what happens, the patient brings the CT scan printouts. To me, those are not adequate to get best information related to my surgical procedure, because that's what I'm going to put forward, the kind of CT scan we need and kind of CT scan person should order to get the maximum information. So your point is valid, Kapil, and that's what I'm starting, that what all is required to know from CT scan. If